Well, I think the basic principles are that movement is medicine. And I feel like the more we know, the better we will do. So, using the skills that you already have and building on those, ensuring that your prescriptive exercise is individualized to meet the needs of this person, right, is imperative.
Hi, everybody. Dhinu Jayaseelan here, editor of the Independent Study Courses. I just got a chance to talk to Dr. Lori Boright. We had to talk about our recent course that we created related to cancer care and orthopedics. She had a lot to say about making this course clinically relevant, which I think is really essential, and that's the intent of this course. We talked a number of things specifically around getting a little bit more confident with clinical practice in this population, kind of understanding maybe when to refer out in this population, and kind of things to think about when having this person that comes in potentially with a primary diagnosis of cancer, or maybe a secondary or a history of cancer. So hopefully this talk is relevant to your clinical practice. You find it interesting. If there's any questions I can answer about the course or this talk, I'm happy to do that. Thanks so much. Dr. Boright, thanks so much for joining us today.
Thank you for having me.
So obviously we're very excited about this cancer course that we put together in collaboration. But for many that might not know you, can you give me kind of intro of who you are and kind of the role you have right now?
Certainly. So I am an assistant professor at Oakland University. That's in Rochester, Michigan, not Oakland, California. Some people get that confused. So we're a suburb of Detroit. And as a function of my academic role, I actually have the unique privilege of coordinating our graduate certificate in oncology rehabilitation. So it's a unique program for post professionals, really targeting best practice development and program development for clinicians who want to further their knowledge and expertise in oncology rehabilitation. I have several other volunteer kind of hats that I wear. I'm the co-chair of APTA Michigan's Oncology Rehabilitation Special Interest Group. We are the first state level special interest group dedicated to advocacy for persons living with and beyond cancer, as well as best practice clinical development for our statewide workforce. I am the chair of APT Oncology's Hospice and Palliative Care SIG, as well as an associate editor for Oncology Rehabilitation in Practice, which is our brand new journal sponsored by APTA Oncology. So we are really trying to bridge the gap between evidence and clinical practice with this journal. So that's been an exciting endeavor as well.
So you play a lot of roles, wear a lot of hats, and are an expert in the cancer area. And so just thinking personally, we had admissions recently, and a lot of students kind of come into school thinking they're going to do orthopedic, sports, maybe peds or something in neuro. Not a ton of students come in thinking they're going to be passionate about oncology or cancer care. Kind of tell me how you got interested in that, and maybe what sparked that passion for you.
Well, for me, as for many in my cohort of colleagues that have grown up in this domain of oncology rehabilitation, we've had a personal experience with it. So one of my things I will impart, as we have this discussion, is it's really not if, it's when that our profession, physical therapy, occupational therapy, the rehab disciplines, will encounter people living with and beyond cancer just due to the high prevalence. So I had in my life, both of my parents had subsequent cancer diagnoses within a year of each other, different types of cancer, but in both circumstances, they were left wanting and needing something more. And it really started to, kind of eat away at me a little bit, and knowing what I know about how exercise is so important, and movement, it really is medicine. That really sparked my exploration. There wasn't a lot, even speaking with their medical team, multiple members of their multiple medical teams. So I began an investigative journey, and at that time there really wasn't a lot for our profession in terms of continued education. So I sought a program at the University of Northern Colorado's Cancer Rehab Institute. It was a week-long program for a cancer rehab specialty certification. At that same time, Oakland University, where I currently work, was developing the certificate program that I now coordinate. So it was a little fortuitous. Once I had completed that specialty certification, it sort of sparked within me the need to fill that gap of knowledge and evidence. So that's what precipitated my return to school, and the, again, fortuitous pairing of myself and my mentors at Oakland University to really work towards bridging that gap. That culminated in a monumental work in the development of our textbook, Oncology Rehabilitation, a comprehensive guidebook for clinicians, which was published a couple of years ago. So it took quite a while to get that off the ground. And now, I really, being on the academic side, a lot of my clinical roles are related more to research, and looking at prehabilitation and the effects of comprehensive engagement with the hospice and palliative care team. That's sort of how it's evolved, but it's been a wonderful journey, and something, you sort of spoke to this at the beginning of your question, Dhinu. When I started my journey in physical therapy, it's not something I ever would have, foreseen. And that just speaks to the wonderful depth and breadth of our profession.
Yeah, yeah, and even if people are treating a lot of different populations, there still is a tendency to kind of stick to your own setting, which leads to a certain population that you'll see pretty consistently. One of the reasons why we put this course together is because we know a lot of people with cancer end up in orthopedic settings. Um, and why do you think it's so important for ortho clinicians to know about cancer or ortho clinicians to know about neuro? Like, why is it so important that we have this course? And maybe what are some clinical pearls you would have for ortho clinicians that are treating this population?
Well, I want to answer this question, first of all, by thanking you for having the vision, because I really think it is important that our profession, sort of bridge the gaps between specialty areas of practice. Related to why it's important that orthopedic clinicians understand some basic cancer principles, as I kind of mentioned and prefaced earlier. I didn't preface this, but I do a lot of entry level education with, my oncology rehab roles. Um, and one of the mantras that we impart, early and often, is that it's not if, it's when you see a person who has either an active cancer diagnosis or a cancer diagnosis in their history. Due to medical advancements, cancer is considered more of a chronic illness now as opposed to a life limiting illness. Certainly, that still is the circumstance, but again, because we have advanced in early diagnosis and treatment, we're improving the quality of life for those living with and beyond cancer diagnoses. So really, that's the big thing, is that it's not if, it's when. So basic understanding of these principles related to medical management and the adverse effects that are resultant of them. That's really where we come in as rehab clinicians. So another sort of thing that I impart is that our colleagues in medical, surgical, and radiation oncology are definitely, they are needed to save lives. So they add days to life. But our position in rehabilitation, certainly as physical therapists, and this extends to OT and speech language pathology as well, we add life to days. So we are very, very integral and important in that spectrum.
That's a really interesting way to think about it. To improve the quality of life is something that's really an amazing part of our profession. Um, and with this population, I'll speak maybe anecdotally, is I I think we have a tendency to maybe be gun shy in treating individuals that have a history of cancer. It's always a contraindication for management. It's why can't you do something? Oh, they have a history of cancer. Why can't you do something? They have a history of cancer. And so we kind of get nervous when we see that history of cancer on that intake form. What are some maybe misnomers do you think that are out there, or some things that we could be a little bit more aggressive with when it comes to cancer care? What do you think we should be really focusing in on in terms of progressing versus kind of avoiding in that sense when it comes to specifically maybe orthopedic clinical practice?
I think those are really intuitive points to know, and I think it isn't common. And I think addressing some of our own, um, not necessarily weaknesses, but fears related to approaching a person diagnosed with cancer is really, really important. They're not all that different than other patients. And so that's really one thing to come to understand. Um, Related to having cancer be a contraindication to everything, it's because there isn't a lot of evidence. It's almost like doing research on a woman who is pregnant, right? We don't want to have all of those risk factors and then the potential consequences that may come from doing things that are a little more experimental. But we are advancing and moving forward in terms of, we're a fairly young specialty area of practice. So with that comes, a little uncertainty. We historically have defaulted to using evidence in the geriatric population, right, as sort of our basis for doing these things. And so with that, I think comes the consequence. Even in geriatrics, I think we underdose, right? And so I think the same is true for the oncology population. We're getting better at that. So recognizing that as a potential limitation, I think one thing that helps me get over that barrier is certainly something that this course will help in terms of bridging the knowledge gap. And the thing to understand is that there is a consequence to radiation oncology, to chemotherapeutic agents, and certainly, there's adverse effects resultant from surgery as well. But if we look at the general context of that, I am not myself today.
That's okay.
Okay, so just casually, what I want to say about this is that we want to approach these patients not all that different than other patients, and understand that there are adverse effects. So, cardiotoxicity, cancer related fatigue. And we do know that exercise is a wonderful, when it is prescribed well, wonderful intervention to help persons living with and beyond cancer overcome um, those adverse effects. So, understanding the adverse effect, the consequence, and then just applying our principles that we are well positioned to apply, right? We are exercise specialists, movement specialists, getting to know our patients one on one. And one other additional thing that is so very important is the taking vitals at every session, before, during, and after, so we understand how our patients are responding to our prescriptive exercise. I think another important thing to note about oncology patients specifically is that they often underreport their symptoms, and they will tell you they are just happy to be alive.
Mhm.
So that imparts the other really important principle of getting to know our patients well and providing patient-centered holistic interventions so that we can respond to those needs. If they are using an RPE scale and still underreporting their fatigue, but we're taking vitals on a consistent basis, we can see that there might be, an issue with them underreporting their fatigue. Um, so I think, again, knowing that we are well positioned, using that knowledge to build our confidence, using our resources. That's another way, to overcome some of that discomfort, and maybe even, dare I say, imposter syndrome, right? Am I capable of managing this population? Um, I think, going back to my initial comment and being grateful about how our academies are sort of, working to bridge some of these, areas of knowledge gap and meeting the needs of our respective specialty area practitioners. I think the academies also provide wonderful amounts of information and resources. Some of those are human resources. I'm definitely one of them who, I'm pretty active in some of our chat groups and our listservs where, our colleagues are asking questions about things. So I can't presume to know everything. And I'm very transparent if I don't know something, especially with my students and even my colleagues and our residents. But I feel very fortunate that I have a wonderful network of, clinical partners as well as colleagues who can help, find answers to things and help even mentor if that should be needed.
Yeah. Yeah, there's always more resources that we can refer to, and there's always somebody else that probably has a little bit more knowledge than us. And I think using our resources and leveraging each other is an essential part of obviously professional development, but also helping people get better and get them well, especially when we're not as confident or comfortable or expert in that content area. And so, especially for our Ortho Academy members, I mean, a number of them obviously will have worked with people with cancer. As you know, the longer people live, the more likely it is that they'll have some sort of diagnosis that'll affect how they move, how they function. Um, and so, I think going back to the basics, as you're kind of talking about, is you have basic skills of understanding vitals, understanding fatigability, understanding effort, and matching our interventions to that person's capacity, and maybe trying to push that a little bit. Those are some basic skills that every clinician has. Um, they just need to be transferred and applied to a different population, and so doing that more frequently and coming back to the evidence when it's changing, that's important. Hopefully this course gives people a little bit more confidence in a starting point potentially. But importantly, I think you keep mentioning a number of different gaps, and those gaps are expected, as you've noticed, because um, when you think about ethical research and you think about pregnancy, you think about pediatrics, you think about cancer, there's certain gaps that will potentially exist for a period of time. And so we have to make assumptions in some cases or transfer knowledge elsewhere. Um, Putting my researcher hat on a tiny bit, though, I always want to know what those gaps are. So then when I go into a clinical interaction, I need to know maybe where are some barriers to me getting this person better, and how do I fill those gaps? Maybe if there isn't research, what do I do? Or if I can be involved in that research, where would that kind of area be? So if you had to think about like some of the major gaps from your perspective in the current literature, what would some of those be?
So I will start by saying I'm really very glad that in the last like decade and a half, we're really starting to move in the direction of efficacy for exercise for our, this specialty population. That said, there still continue to be significant barriers to referral pathways. How do we gain access to these individuals who need us so much? Certainly are not standard of practice. We are behind the times in terms of every cancer patient should have access and be working with a rehabilitation clinician at some point in their journey. It is standard of practice in Australia, for example. So every person diagnosed and living with and beyond cancer gets a referral to a rehab clinician early in their trajectory. So that is something we are working towards, but it's also something we need to have a better understanding about. Where are the barriers? Why is this not happening on a regular and consistent basis? Other areas related to exercise, I know I started with that in terms of there being a burgeoning, um, you know, more evidence to support that, but related specifically to how exercise modulates inflammation and how inflammation perpetuates cancer diagnoses, certainly needs to be better understood so that we can have more effective prescriptive exercises. One area that is of particular interest to me is prehabilitation. It's pretty standard in orthopedics, but it is not standard in oncology. So it stands to reason if we were able to access and work with every patient before they underwent chemotherapy surgery, right? We do that again for our orthopedic surgical patients, radiation therapy, that we can fortify their physiologic system to withstand what we know is coming and will be, a physiologic insult. So that again is an area, especially in the head and neck cancer population, for me specifically, is something that really needs to be addressed, but spans multiple diagnoses. We have growing evidence in colorectal cancer, prostate cancer, and breast cancer. Those are three areas that really there is a growing body of evidence to support prehab for those diagnoses, but we need it across the board. Other areas of interest for me specifically, in terms of palliative care, the effective um, um, interventions of a rehab clinician on the multidisciplinary palliative care team, and what that means to, length of stay in the hospital, potential unnecessary hospital readmission. So there's, administrative implications to a lot of this work as well. I have colleagues that work in the adolescent and young adult population, and there is a lot of gaps related to maintaining and returning to work in that population if they are undergoing active treatment or had treatment, in their past, and they are dealing with adverse effects that may, prohibit. Their current and future work environment, and then the economic implications of that. um, I think I will complete. There's a lot of gaps, but work towards development of some clinical practice guidelines in the oncology domain. It is especially challenging because really every person living with and beyond cancer has a different trajectory. So it's really difficult to be prescriptive related to that. But I think if we could take a step back and look at less about the diagnoses maybe, and more about the adverse effect profiles like cancer related fatigue and cardiotoxicity, and develop some clinical practice guidelines around those specifically, I think it will really help to raise the efficacy and move things forward toward more consistent referral to rehab along the survivorship trajectory.
Sure. Yeah, that there's always going to be more gaps, and I think acknowledging those gaps is as essential as filling those. And when it comes to research, we should always find more questions that need to be answered. I think that's the ongoing hope. Um, but I guess when we create these courses, at least it's my hope and my intention that these courses help to improve patient care and improve somebody's quality of life through integration into clinical practice. And ideally, obviously, that helps people with CEUs, but that's not our intent, is to just check a box to get licensure. But even still, I'm hopeful this course at least will help people feel more confident, give people tools to work with the cancer population, the oncology population, from a musculoskeletal specific lens. But there's still going to be a need in some cases to refer out to somebody that has more expertise, right? Just as if I'm referring to a neuro specialist for somebody that had a stroke. The other day in clinic, I saw somebody with an amputation, below knee amputation. I know that person can get better with somebody else versus me, despite my background. So, in what instances do you feel like, as much as we know the basics, we can take vitals, we can progressively load people up, we can progressively help people move better and exercise better, we can be careful about known adverse events that exist or might exist? What are maybe some scenarios or some patient maybe cases that you feel like, as much as somebody might do well, they might not do great? And what scenarios would that person maybe benefit from referral to an oncology specialist? Do you have some of those on top of mind, do you think?
I think, yeah, there are maybe a few instances, and really, I wanted to go back to the basis for the course. Danu, I think you said it very eloquently. We want to equip clinicians with some basic skills, but anytime there is that sort of gut feeling, just as you had mentioned, right? We have to be honest with ourselves about, the care of this patient really is at the forefront. It isn't about us, it's about the patient. And if you have a colleague that is better suited, has a better skill set, that would be the obvious, first thing. If you don't have the competence or confidence, really, right? And maybe it could be more of a collaborative situation so you can learn and grow. If you have a resource proximal to you, I mean, that would be, a good recommendation right there. um, I am going to start by saying if there are issues with lymphedema. So, one of my soapboxes is that historically, oncology rehabilitation equals lymphedema. That's really never been the case, but that is sort of like the basic understanding, the word on the street, so to speak, even amongst in our profession and outside of our profession with our medical colleagues. So certainly, if there are concerns for lymphedema, it does require a specialized skill set to effectively manage. So any cases where that is suspected, certainly there can be surveillance of that, without that specialty skill set. So that would probably be my first recommendation. Any concerns where lymphedema might be a problem. I would also say advanced cancer cases, those where metastatic disease is either suspected or confirmed. And the reason I would recommend that is because our medical team will probably be using multiple modalities to manage that, right? So there might be a surgical intervention, there might be chemotherapy in combination with radiation, and then you have the sort of fold over um, um, adverse effect profile situation where cardiotoxicity might be combined with radiation induced fibrosis, and so those cases are complex even for those of us with specialty skill sets. So those would probably be the primary situations where referral would be best. um I also think if there is a severe cardiotoxicity or again issue with significant fibrotic tissue, um it certainly is within the scope of an orthopedic physical therapist to manage that. But I guess I would just implore the individual to use the resources, gain the knowledge and skill, um, maybe not even skill so much, but confidence in the skill, right, to apply what they already know to this population. Um, and I guess I will just kind of reinforce that there are resources for confidence building. And again, if you have somebody close in clinic, or you're in your town that you can communicate with and maybe even meet with, just to ensure you're proficient in management, I would encourage that. But the bottom line is that these persons living with and beyond cancer really are not all that different. You just need to look at them a little bit through a little bit different lens sometimes. And I guess I will say this: sometimes we get into our routine of seeing the same relative diagnoses over and over again, and that can be a little anxiety producing as well. If you have someone who has prostate cancer in their history, for example, and they're reporting increased fatigue after having a joint replacement, that is something that is relatively common. And maybe just having that knowledge and reflection that maybe this is a situation where their cancer related fatigue is still not fully resolved, but they're dealing with a major physiologic insult and having a hard time getting over that. um, so again, I think this course will do its due diligence in imparting some of that, and build confidence towards the orthopedic specialist knowing and being able to manage some of that on their own.
Yeah, and I can kind of speak to that personally by saying when I was going through and editing these sections of the course, um, there is a lot of overlap between what I already know and what I've been kind of reading and learning, but it definitely deepened my understanding of how to manage individuals that I'll be seeing in clinic, which I found very helpful because it is more frequent that I'm seeing that little box on the intake form checked to say history of cancer, and I follow up, and I'm starting to feel a little bit more confident. But I definitely thought that going through and just reading your course and the other sections of the course, it really definitely gave me a little bit more. I think a good word is what you mentioned is confidence, is just being um, willing to take what I know and apply it. Because sometimes when there's a different population, you start to feel a little bit more nervous or whatever it might be. And so then if you had to think about maybe a couple key points, right? So we talked about just using the skills you have to be more confident, using the course hopefully to give you more of that confidence, recognizing that certain situations might benefit a little bit more from someone else taking another look or maybe co-treating with you potentially. On top of that, what are some main kind of takeaways you would want somebody that's kind of potentially interested in this course to have, or somebody that's going through and taking the course? What are some takeaways you would want them to know about maybe the intersection between ortho and oncology, um, from your perspective, from your background, from your clinical practice?
Well, I think the basic principles are that movement is medicine, and I feel like the more we know, the better we will do. So using the skills that you already have and building on those, um, ensuring that your prescriptive exercise is individualized to meet the needs of this person, right? Um, is imperative. And I hope the theme of this is that we do this regardless of if we're working with an oncology um, person with an oncology diagnosis or not. Um, and I feel that again, our profession is underutilized in this domain. So the more we know, the more that we can have other specialty areas advocating that this person, or in the context of the population, this population really deserves our intervention and our care. I think it's better for us as a profession as well.
Yeah, completely agree. I think the more we can know about different populations, the better, because different populations are going to show up in our clinic. People that had a stroke are going to come in with orthopedic problems. People with pediatric issues are going to be coming into orthopedic clinics later in life. And so the more we know, the better, obviously. And in this case, it's so essential, in my opinion, to know more about what is cancer, what does cancer mean for people in physical therapy, and how can we be confident in managing those individuals that we'll consistently see, I think, going forward. I think those are important pieces of this course, and I really do appreciate you taking the time. I want listeners and viewers to realize that it's not as easy as just kind of sitting down for a couple minutes to put this course together, but it does take a lot of time and effort, and so I appreciate you putting that together with your expertise, and then Dr. Huber's expertise to put your section of the course together for our members. So I definitely appreciate that.
Oh, well, we were delighted to do it, Danu, and I appreciate the opportunity to impart a lot of this, really necessary content, if only, to bolster confidence and provide a little bit different lens from, which we already are movement and exercise experts. So Megan Huber has gotten married. She's Megan Sontag now, and I would be remiss if I didn't give her a nice shout out for her support and again certainly for the Orthopedic Academy for the vision and the opportunity to really bridge and sort of branch our profession.
Yeah, absolutely. Yeah. Thank you for putting the course together, and thanks for having this chat with me today about it.
I am grateful. Thanks, Danu.